These two videos illustrate some of the paradoxical features of Parkinson's disease. Notice in the top video the patient's quite able to catch a ball thrown to them, but in the bottom video is having tremendous difficulty taking a cup which is offered to him. And so these are very specific dysfunctions. The symptoms of Parkinson's disease then include things like bradykinesia, which is the inability to initiate voluntary movements, but not the loss of responsive movements. So Parkinson's patients often adapt to this inability to initiate movement by tricking themselves, by getting them to respond to cues in the environment. You'll notice also, particularly in the bottom video, resting tremor, but what's not obvious is things like cognitive impairment, including hallucinations and muscle rigidity. The hallmark pathogenesis of Parkinson's disease is the accumulation of a protein called alpha-synuclein, which misfolds and then aggregates in dopaminergic neurons, leading to their death. And it's specific, or largely specific, to nigrostriatal pathway from the basal ganglia, from the substantia nigra to the striatum, and this results in a loss of excitatory drive to the cortex and the symptoms that we've just seen in the videos. The aggregation of alpha-synuclein causes what's been called Lewy bodies. So these are lumps of alpha-synuclein, and whereas most cases of Parkinson's are idiopathic, that is random if you like, some of them, the minority, are due to mutations, and these mutations are such that favour the aggregation of alpha-synuclein, favouring the model that it's caused by some dysfunction in the genes controlling alpha-synuclein production. Parkinson's disease specifically involves degeneration of dopaminergic input to the striatum. You don't actually see any symptoms until there's as few as 20 or 40% of neurons remaining. So you can lose 60 or even 80% of neurons before you start seeing any symptoms. And it's specifically the nigrostriatal pathway. And as I said before, this results in this loss of excitatory drive to the cortex. This slide is here to remind you of the three main pathways involving dopamine in the brain, so that you can distinguish them from other pathologies such as schizophrenia. You'll see the mesocortical pathway, which is projecting from the midbrain through the cortex. This is involved in schizophrenia when we have an excess of the D2 subtype of receptor, but you'll also be able to trace the tubero-infundibular pathway or the tubero-hypophyseal pathway, which is from the hypothalamus, from the brain to the hypothalamus, and thence to the pituitary, and this controls lactation, which is why people on antipsychotics exhibit gynecomastia. And then you have the mesolimbic pathway, which you can kind of lump together with the mesocortical pathway. It too originates in the midbrain, but projects to the limbic system, which is involved in emotion, and here a paucity or a reduction in D1 signalling is associated, you may remember, with the negative symptoms of schizophrenia. So those are the two. I've said there are three, but lumping the mesocortical and mesolimbic together, those are the two other of the three pathways. We're interested today in the third one, which projects from the substantia nigra, which is so named because it stains black, so black substance, to the striatum, which lies just under the cortex. So why does degeneration of the nigrostriatal pathway cause movement defects. Here's a diagram which has more detail than you'll need to know, but is enough for me to make an explanation. On the first level, you'll notice that the output, which is on the right, is excitatory. The thalamus projects to the motor cortex. Essentially, this input, if you look at on the left, PC at the bottom left is the pars compacta, part of the substantia nigra. That's projected into the striatum, and where the cross is by the PD represents the loss of those neurons. From there, the pathway splits into two. And what's interesting is that, as you notice in the box representing the striatum, there's an excitatory and an inhibitory pathway. These are both dopaminergic, but as you know, D1 receptors are excitatory and D2 are inhibitory. That's why we've got both excitatory and inhibitory receptors. So why does global loss of this input not just simply cancel out because we've got a plus and a minus together? The reason for that is if you look at that pathway a bit more closely, you'll notice it splits into two branches, and there's a series of minuses and pluses. And if you add them all up, you've effectively got one, they both end up having an inhibitory input onto the thalamus. So in other words, loss of those dopaminergic neurons that crosses on the PD results in an increase in the inhibitory input to the thalamus, which has a result of having less output to the motor cortex. So the take-home message of this is that although it's both D1 and D2, that is both excitatory and inhibitory dopamine receptors which are being lost, because they're involved in two distinct pathways, the net result is the same, a loss of excitation to the motor cortex. This slide represents the striatal pathways in a slightly different form, and I put it here because I want to invite you to work out where the D1 and the D2 receptors will be in this pathway. So if you look at where it says striatum, you'll notice that there are two glutamate inputs and two dopamine inputs. You should be able to work out which is D1 and D2 from your knowledge of the receptors. Don't worry if you can't do it, it's just an extra.